At the level of the Ministry of Health, we are keen on 3 areas. One is to ensure that every Kenyan has access to a skilled, motivated, supported health worker. Now, in your case, you should replace that health worker with a cardiovascular care competent worker. Then now you start defining it. That's the first thing that we are very keen on. Number 2, we are keen to ensure that what that worker does is aligned with what we can pay for. And number 3, we are very keen to ensure that this is in adequate numbers and that we can be able, that it is in adequate numbers and that we can be able to ascertain the quality of the work that is done. So in terms of the health workforce, a number of things, of course, come to mind. 1 is the training. 2 is how people are absorbed into the health system through employment. And 3, how they are distributed. The issues around management and how they exit. It is very important that we engage with our universities on how we create a competent health workforce that can deliver cardiovascular care services at the prevention level, at the treatment level, and it is very important that you look at how you can be able to help us determine what that means, because as I've mentioned, what is right comes from you, not from us. The third priority area is on commodities, what we call commodity security. We learned from COVID-19 that you can design very good healthcare systems. But if there is a shocker like COVID pandemic, if there's a war somewhere, recently there was this issue between Israel and Iran, if borders are locked, if there's a currency issue, the healthcare system can be vulnerable to a lot of things. And so how do we ensure that our health products and technologies are assured? 1, we want to try and invest in local manufacturing or facilitate local manufacturing so that we move commodities from 23% of our essential list that we manufacture locally to 50%. Now the question is, all of these products that you use in the cardiovascular care, are they manufactured here locally? How can we manufacture them locally? Is it possible? We are talking about technology transfer. We are talking about active pharmaceutical partnerships around active pharmaceutical ingredients. And certainly, we are talking about use of what we call contract manufacturing, where the companies that some of them are here can now contract some of our local companies to formulate or manufacture or do some of those products here. So that's very key. But number 2, that is also very key for us in commodity security is what we call need management. Need management means that we link what you require, what you prescribe for patients with what we purchase, whether we are purchasing it by contracting from manufacturers or whether we purchase it from suppliers. And this is where we have now decided to establish what we call formulary committees. And formulary committees will 80% be determined by the professionals who interact with patients. And that's where you come in. 10% will be policy, like my good colleague, Dr. Gadesha. and another 10% will be the people who do the supply chain and logistics. So that then we are clear that what patients need is what is bought or what is manufactured. And you can see we've taken that power back to you. That power means that the responsibility is also on your end. That in the very near future, when there is no commodities for cardiovascular care, you should ask yourself whether you are engaging properly with the healthcare system. The fourth priority area is on digitization. And you've seen the rollout of the integrated health information and technology system. We are digitizing public facilities, but even for private facilities, they have to plug in into this digital health superhighway. That helps us with, one, making sure that we have data that we can use for policy making and for resource deployment. But number two, which is very important, it helps us with efficiency in the healthcare system. What do we mean by that? It means that if an echo is not quality, even though it's user dependent, we will know that this echo, this patient has undergone echo twice or 3 times before diagnosis. So it's very important to know that this facility is not giving the quality. So next time, you can direct patients to the first point of care where they are going to get the quality. So that you save the patient's time, you save the money, and we also save the healthcare system money. Eventually, the system becomes efficient. The last thing that it helps us with is the data portability for patients, particularly for referral management. Having looked at this UHC architecture, the way that we've talked about it, you then now need to do 2 other things. One is how do we determine what we call clinical workflows? How do patients enter the healthcare system and how do they exit? That can only be determined by you. Certainly we will facilitate the environment that enables you to determine that, because today our patients are really suffering. In all hospitals, whether it is in the public or in the private, and we are establishing, now we are enacting a quality of care and patient safety bill that somehow puts the legal framework for that.